السلام عليكم ورحمة الله وبركاته. مرحبا بكم جميعا. Hello everyone and welcome to today's symposium, which is part of the ongoing academic activity of the Sudanese Society for Breast Imaging. Since our establishment in 2018, we have been dedicated to early breast cancer detection in our country, Sudan. Over the years, we have worked closely with healthcare institutions, voluntary organizations, universities, and other specialties to ensure that the patient receive timely diagnosis and appropriate treatment. Despite the challenges brought by the war in our country, Sudan, our commitment to this mission have never ended. For the last 2 years, we resumed our efforts by organizing free clinics in safe areas and continuing our scientific activities remotely. We are warmly welcome you today to this monthly academic activity, and today's session will cover an important topic. Although it is rare, but it is very important. We will talk today about granulomatous mastitis, and today it will be conducted in collaboration with our colleagues in surgery and histopathology. From surgery, Mr. Omer F, he is the head of surgical department in Soba University Hospital, and he is associated professor of surgery in University of Khartoum. From histopathology is Dr. Nadia D. She is histopathologist in Soba Hospital and Royal Care International Hospital. And also, I will contribute to this presentation today. Me, Sara M. I am radiology consultant here in the Imam Abdurrahman bin Faisal University. So please welcome with me Mr. Omer, who will start this presentation today. The mic is yours, Mr. Omer. You can share.
Thank you very much, Sara, for this kind introduction. And I would like to thank the Sudanese Society of Breast Imaging and Sudanese Society of Radiology for this kind invitation to share and to talk in this webinar. I'm glad to share this webinar with Dr. Nadia D, who is an old friend of mine for a long time. He's been in the University of Khartoum, Soba, Stack, and we shared a lot of experience in general and private hospital. And Dr. Sara, it's an honor to share this webinar with you today. As Sara introduced the topic, we're going to talk today about granulomatous mastitis. Although it is relatively a rare disease, but granulomatous mastitis it has a dilemma of patient suffering, dilemma of diagnosis, and dilemma of treatment. So today we're going to shed some light on the topic and try to explore the new options in diagnosis and treatment. So granulomatous mastitis is a rare chronic inflammatory condition of the breast, and it was first identified in 1972. It's primarily affected young premenopausal women and characterized by sterile abscess and granulomatous formation, and commonly present the breast mass that mimic malignancy, and also present commonly with multiple masses and abscesses which can open and form sinuses. Etiology of granulomatous mastitis remains unclear, with proposed link to autoimmune and infectious origin. Granulomatous mastitis predominantly affect women of reproductive age. That's why, I mean, most of the people who encounter granulomatous mastitis patient, they will notice that it is affecting ladies after lactation, during lactation, before pregnancy, during pregnancy. This most of the cases they present with those groups. High prevalence reported in Hispanic and Mediterranean population, although recently we see it a lot in our continent, the African continent. We see a lot of cases, and we think the prevalence and the incidence increasing in our continents. No direct genetic link identified, but environmental and hormonal factor may contribute. And cases have been increasing, as I say, in recent decades. Etiology of granulomatous remain unknown, especially in the idiopathic, in most cases, and we call that the idiopathic cases. Proposed mechanism for these idiopathic cases include an autoimmune response against the breast ductal protein, infectious agent like Corynebacterium species implicated in some cases, in addition to atypical mycobacterium and mycobacterium. Hormonal change during lactation may trigger the inflammatory response. All these are proposed causes for the idiopathic granulomatous mastitis. And as I say, there is another cause, which is the infectious cause due to mycobacterium, atypical mycobacterium, and other infection. The clinical feature, the common symptoms include unilateral breast mass, pain, and erythema. So typically, if the patient presents like that, you will think of abscess, but characteristically, these patients, they present with typical clinical abscess, but without the constitutional symptoms like the fever and the malaise and the illness that comes with abscesses. Usually it is minimum in these cases. And usually when they present with masses, you usually find not only one mass, but several masses which happen in few days to few weeks. Frequently associated with nipple retraction, if it is exists for a while, usually it sometimes associated with nipple retraction and skin changes. Abscess formation and fistula are typical complication. If you have those, most of the time when patient presented with these symptoms, people start giving antibiotics, and then after 3 or 4 days, it becomes fluctuant and form an abscess. Either they incise it or open spontaneously, and they form fistula and abscesses and fistulas and sinuses. Patients often report prior lactation or pregnancy, as we said before, and systematic symptoms like fever are rare, differentiated from the infectious causes. Typically, our encounter with this patient is usually a patient who went to one surgeon who incised an abscess and then continue dressing for a week or two, and then after a while he had another surgery, and then he go to another surgeon who diagnosed differently and give different kind of antibiotic, and then incise it again. And this is a typical story of patient with granulomatous mastitis. So if you see a patient who is running around from different surgeon carrying different antibiotic, always think of granulomatous mastitis. So they usually present with multiple abscesses, not like single abscess. Sometimes they present with single abscess, you open it, and then the abscess, you'll find that different part of the breast start forming masses and then abscesses. So usually patient came after a while with different incision, different sinuses and discharge, like this one. Always they come like this. So patient had different incision, sinuses, discharge, and disfigurement of the breast, nipple, sometimes nipple retraction. Always it will make you suspect to something wrong. The differential diagnosis, breast abscess, as you say, we differentiate that by the infectious etiology and the systemic sign. Usually, granulomatous does not present with the typical constitutional symptoms of breast abscess. Breast carcinoma, also exclude that by imaging and biopsy finding, and they are different because these people, they present like suddenly a week, 10 days of pain, swelling, and then form an abscess. So usually you exclude the malignancy, although you have to do imaging and biopsy. Sarcoidosis, typically systemic with pulmonary and lymph node involvement. Tuberculosis mastitis, this is common. You have to exclude it, especially in developing country like Sudan. So you take a biopsy, examine it for granuloma, examine it for acid-fast bacilli, do CRP to diagnose tuberculosis. And other idiopathic disorder like vasculitis, like Wegener's and different vasculitis, can be a differential diagnosis. Okay. I will leave Sarah talk about this. Periductal mastitis is another differential diagnosis, and this can coexist with idiopathic granulomastitis, and mainly in premenopausal woman, nipple retraction and non-bloody discharge. And it is again one of the differential is periductal mastitis with duct ectasia complex.
Thank you, Mr. Omer, for this
Yes.
nice introduction. So
Okay.
please, may I will share?
Yeah. Okay. So when you do that, then you go for radiology, and I will let Dr. Sara continue from here.
Okay.
This is just before you share the Sara. This is a diagnostic workup. So clinical evaluation includes Sara history, physical examination, then mammography, ultrasound, MRI if needed. Then we do the core biopsy to see if there is granuloma or not, and then we have to do cultural sensitivity from the discharge. This is the normal workup we do for every patient who comes with suspicious of granulomatous mastitis. A biopsy and cultural sensitivity. Okay, Sarah, the
Okay.
microphone is yours.
Okay. Thank you. The screen is clear now?
لا ما شايفين. أنا stop sharing دقيقة. Stop sharing. Okay. Yeah.
Okay. طيب زي ما قال لنا مستر عمر differential diagnosis هو wide. Okay. malignancy, types of malignancy, invasive inflammatory breast carcinoma is one of the differential. And the other important differential is the mastitis. Okay. The problem is that the imaging features and radiological features of granulomatous mastitis, it is not pathognomic, and we cannot, there is no specific findings in radiology, so we can say it is 100% this is granulomatous mastitis. معلش بس الصوت, can we mute please? Okay.
Yeah.
So the differential diagnosis is the invasive and inflammatory breast carcinoma. Usually, the findings will be simulating the granulomatous mastitis. In form of that, there will be irregular speculated masses, architectural distortion, calcification, adenopathy, and also in cases of inflammatory cancer, there is also trabecular and skin thickening and bedo orange, but usually no drainage pus in cases of invasive and inflammatory breast carcinoma.
Excuse me, Sarah, we still see the screen of Mr. Omer.
Okay. طيب.
دقيقة.
السكرين بتاعتك يا سارة differential diagnosis مش؟
Yes,
أيوة.
differential.
ظاهرة أي. دكتورة نادية شايفاها؟
Yes, okay, fine.
لسه ما بديت في الإيميز، هجيب الصور بعد شوية.
Okay, because you are using the same theme. Okay.
Yes, أيوة.
Yeah.
زي ما قلنا الفيرست ديفرنشال دياجنوزيس هو الانفيزيف الانفلاماتوري بريست كارسينوما. طيب ممكن بتكون جريد ميميكالز للجرانيولوماتوس ماستايتس. طب but usually الانفيزيف كارسينوما there is calcification, but in cases of granulomatous mastitis usually بتكون ما عندنا calcifications في الماموجرام. طيب the other differential bacterial mastitis like staph, streptococci infections. Usually there is draining sinus, okay, like in cases of granulomatous mastitis. Sometimes ممكن تكون في negative cultures, but usually بيكون في lack of granuloma formation in biopsy. طيب the other differential also tuberculosis of the breast. بيكون في sinus called abscess, caseating granuloma, والculture may be negative. Sometimes PCR may be diagnostic. Other infective mastitis, other mycobacteria also is differential diagnosis. Sometimes other systemic granulomatous conditions like Wegener's sarcoidosis, it ممكن تكون differential for the granulomatous mastitis. Localized breast fibrosis like the fibrous mastopathy, diabetic mastopathy, also this is differential for granulomatous mastitis. But usually clinical presentation and good history taken and examination will help us in getting the proper diagnosis. Okay. Also periductal mastitis and foreign body granuloma. These are the differential diagnosis of granulomatous mastitis. Now we will go for the imaging. In radiology, we will use usually the mammogram, ultrasound, and MRI. General features in cases of granulomatous mastitis, usually the breast will be affected unilateral rather than bilateral. Okay. So usually any part, any quadrant could be affected, but usually the nipple is not involved. Okay. Morphology زي ما هنشوف في الإيميجينج بعد شوية عادة بتكون كل البيكتشرز irregular, indistinct margins. دي الcommon features in granulomatous mastitis. اوكي. هنبدا بالماموجرام. في الماموجرام findings بيكون عندنا حاجه اسمها asymmetry. بنلقى في difference between the two breasts. زي ما قلنا في irregular, indistinct masses, architectural distortion, skin thickening, and axilla adenopathy. زي ما شايفين this is mammogram of a 44 years old lady. Okay. زي ما شايفين difference in the density of the breast. Okay. This is the mammogram, MLO view, mediolateral oblique. This is the right breast, and this is the left breast. The left breast, there is global asymmetry if we compare to the other breast. And also, there is asymmetry seen posteriorly, and there is axillary adenopathy. There is enlarged lymph node. So these features, typical for granulomatous mastitis? No. This feature, we can see it in a lot of abnormalities. زي ما قلنا في other differential, mainly breast invasive breast cancer. There is also another case, again MLOBU. زي ما شايفين compare من رحمة ربنا احنا يعني دائما بقول في الراديولوجي comparison عندنا two side right and left فبيساعدنا كثير to detect the abnormality. طيب if we compare the right side with the left side, again there is asymmetry. Okay, almost global asymmetry موجودة within the left breast. تمام. ده ال most common finding in this case. Okay. This is the CC view, craniopodal view of the breast. This is the right breast, the left breast. Again, there is focal asymmetry. Okay, and there is some distortion in the breast parenchyma. This is another case for this. Okay, so this is the mammogram. Again, in the right breast, the right breast here is affected. Global asymmetry. زي ما شايفين معايا هنا النبل thickening compared to the periareolar area compared to the left part. So there is abnormal thickening in the periareolar and skin thickening. There is also trabecular thickening. The trabeculae within the breast is thickened and edematous compared to the other side. And also look to the lymph nodes, enlarged, and also it is rounded. There is no fatty hilum. So these are all findings, abnormal findings. Another case, again, global asymmetry, skin thickening, okay. So زي ما شايفين الفايندينجز are not specific. These findings ممكن نشوفها في زي ما قلنا في الانفيزيف and inflammatory breast cancer, and also in cases of breast abscess and infection and inflammation. نجي للالتراساوند finding. Again, هنلقى irregular masses, okay. Usually يمكن نلقى sinuses, also the edema and collection. Sometimes we can find collections in up to 54% of cases. Skin thickening, and again reactive nodes. And in Doppler, we will see hypervascularity, as we can see in these images. These are 4 images of the breast. ما قادرين نشوف distinct masses. The breast parenchyma itself is abnormal, heterogeneous, hypoechoic. There are extensive posterior shadowing. There are increased vascularity. زي ما شايفين في tract formation, tract from these abnormalities up to the superficial and to the skin. Again, these are abnormal areas. Again, abnormal hypoechoic areas with extensive posterior shadowing. Again, there is another case. دي panorama view اللي هي ببساطة multiple ultrasound images. اوكي بناخدها وبعد كده تتجمع في صورة بتاعت panorama. We can take whole breast in one image like this. This is the whole breast. So we can see the whole breast. There is abnormal, hypoechoic, heterogeneous texture involving the whole breast parenchyma, skin thickening, some tract almost reaching the skin. Okay. Here's a subcutaneous, not reaching the skin yet in this image. So the findings, usually we as radiologists, when we see these findings, we will just describe the findings and put our BI-RAD grade. So usually the BI-RAD grade in these cases will be at least BI-RAD 4. Okay, so we will need biopsy to reach the diagnosis. Again, the same findings. This is panorama view. Whole breast parenchyma is abnormal, heterogeneous, okay, indistinct masses. Okay. This is zoomed view from the axilla. We can see this is an enlarged lymph node. This is the lymph node. And this is the fatty hilum. There is abnormal cortical thickening at this area. And it is more hypoechoic than the rest of the cortex. So this is pathological enlarged lymph node. Again, not pathognomic. Okay. Here, indistinct hypoechoic mass, vascular. At least when, as a radiologist, when we see a mass like this, we will put it at least by RAD 4C or even 5. When we see mass like this, indistinct, speculated, increased vascularity. So it is highly malignant for us. Again, the same finding, multiple images. the same findings. MRI can help us, okay, in reaching the diagnosis. And the other important, the importance of MRI is an extension of the disease. So it will help us in seeing the extension of the disease within the breast. Usually, the most important image, the STEER image and T1 with contrast, now we can see these abnormalities within the image. So this is sagittal T1 with contrast, fat SAT. Okay, this is sagittal view. Okay, بتشبه لنا ال MLO view with unilateral oblique in mammogram. شايفين this is the abnormality here. Okay, there is irregular, large irregular abnormal enhancement. Okay, involving almost the central part of the breast and extending almost posteriorly. So within this MRI, we can see the extension of the disease very well. Okay, this is the MRI. Okay, again, with the same patient. Okay, this is the axial view. بيشبه لنا CC view within the MRI, within the mammogram, sorry. Again, there is large area here. Okay, intense irregular enhancement with non-enhancing microabscesses inside. This is area of microabscesses. Again, extension to the skin and almost extension to the posterior part of the breast. Again, this is another patient with involvement of the right breast with the granulomatous mastitis, enlarged right breast, okay, with heterogeneous enhancement, multiple microabscesses inside. And also we can see the abnormal enlarged right axillary lymph node. Again, the same patient with the same findings. And these are the microabscesses within the right breast. Now with the MRI, we can see the extension of the abnormality. Again, multiple masses and almost extension of the whole breast. Okay, with this abnormality. Okay, and these are the collection and the abscesses. So, in imaging features, usually زي ما قلنا, characteristic imaging findings support the diagnosis, but زي ما قلنا, it is not pathognomic. While imaging will aid in disease monitoring and treatment planning. So, now my talk is finished now. I will stop share now and I will give the mic to Dr. Nadia. So we will talk about the histopathological findings in granulomatous mastitis.
Thank you, Sara. Yeah, as you can see here, first you get the patient, you have the suspicious with clinical examination and the history. We talk about the typical history, and then you do the imaging. And the second thing you have to do to confirm what is going on, you have to do a biopsy.
Yes.
And we'll let Dr. Nadia continue here. Nadia,
just
ready?
I will make you co-host, Dr. Nadia.
Yes.
Just a minute. Yes, now you are co-host. Yes, you can share.
Can you see it?
Yeah.
Okay. ازيكم كلكم؟ I do pathology. Both of the speakers have covered part of it. But the important thing is that granulomatous mastitis is an underdiagnosed and understudied benign. This is the important thing. It is a benign inflammatory condition of the disease, disease of the breast. And the accurate diagnosis is confined by its mimicry of other breast pathologies, most important of which are infectious mastitis and abscess, which are inflammatory as well. But the important one is malignancy. And there is limited clinical knowledge of disease. The etiology is still not 100% known. And this definition would go for the idiopathic type more than, why isn't it moving forward? Yes. It is characterized by, pathologically, it's characterized by lobulocentric, destructive, granulomatous inflammation, relatively sparing the interlobular stroma. And a definitive diagnosis can be made by histopathological examination. The diagnosis can be readily made on a needle core biopsy, and in an excision biopsy, it consists of mixed inflammation with the lobular pattern, which is, of course, then even more evident. I'd like to, at this point, to revise a bit inflammation. Inflammation is the response of living tissue to injury. So it has to be living tissue to show inflammation, and injury, that is the cause of the inflammation. So when we are talking about idiopathic granulomatous mastitis, those are the cases where we have not found out what is causing the inflammation. There must be some sort of injury, but we are ignorant. Until now, we are ignorant why it is happening. Now, the types of inflammation are in two big categories divided into acute and chronic. And as usual in life, nothing is so cut. It's not just acute or just a chronic, but these are the two basic, and you have the shady areas in between. Inflammation, acute inflammation is inflammation of rapid onset and of short duration, usually followed by resolution and or repair. And this is so rapid that it can take minutes to manifest. Like, for example, when we have an insect bite, the response can be immediate. And this is in minutes to days, up to days, like in an abscess, for example. Accumulation of fluid with plasma proteins, extravasation of platelets, and inflammatory cells. And these are the neutrophils in this condition. And these three make up all that explains acute inflammation, how it comes about. The outcome is usually, in most cases, it is because there is really a minimum amount of damage, so it is complete resolution. Everything goes back to normal. But we can have complications, like disease can develop an abscess, and then we do have some tissue damage. It can progress to become chronic when the inflammation cannot be overcome. Now, chronic inflammation is insidious onset, so it starts more slowly and has a prolonged duration, and there is always tissue destruction and scarring. So we have the inflammation and the healing taking place at the same time. Therefore, this chronic inflammation usually takes weeks and months to sometimes years. We have angiogenesis, which is the formation of blood vessels, mononuclear cells, and these are the macrophages, lymphocytes, and plasma cells. And we always have fibrosis. Following acute, we can have, so how does chronic take place? It can be a complication or following acute that cannot be overcome. The injurious agent cannot be overcome. So we go from acute to chronic. So chronic can start as a complication of acute. We can have repeated attacks of acute, which eventually is chronic. Then we have conditions that start from the beginning as a chronic inflammation. Chronic inflammation can be divided into specific, to maybe non-specific or granulomatous. So once I diagnose chronic, I have to say what type of chronic it is. Is it a non-specific chronic inflammation like happens in inflammatory bowel disease, for example? Or is it or in any wound that has taken a long time? Or is it a special type, which is the granulomatous? Acute inflammation, you can see in these three pictures, you can see the edema, you can see the blood vessel, maybe I should show it. You can see these capillaries filled with platelets that are with corpuscles, and they are red blood corpuscles, and how dilated it is. There is total edema, and you can see the cells, which I think in this picture, you can see these are neutrophils. So lots of neutrophils. And these are the features of acute inflammation. Chronic inflammation, non-specific chronic inflammation. This diagram is from the kidney, and you can see that here there is a renal glomerulus. You can see a lot of fibrosis, and you can see not so much edema like in acute inflammation, but still you can see the infiltrate of mononuclear cells. The second picture is from the prostate. Again, you can see fibrosis, and you can see chronic inflammatory cells in chronic prostatitis. Chronic inflammation, granulomatous chronic inflammation, is characterized by a granuloma, which is an aggregate of modified macrophages. We call them epithelioid cells. And here in a lymph node, you can see this structure is a collection, an aggregate of modified macrophages, the so-called epithelioid cells, and it forms a granuloma. In this picture, you can see a granuloma with one large cell multinucleated, which are the giant cells, also formed from macrophages. So different types of granuloma. We have so many different types of granuloma. You can have them just blunt like this. You can have them like this with multinucleated giant cells. And in the breast tissue, the important thing, when now we come back to pathology of the breast, in the breast tissue, we can see the lobule formation, the lobular granulomatous mastitis. You can see these collections. These are granulomas, the power here, but you can see the rest of the architecture of the breast lobules. And here you have a granulomatous inflammation. More of it, and some of them in this picture, you can see the multinucleated giant cells in the granulomatous lesions. In this picture, you can see an area that is in the section because of the way we treat sections. The fat has been dissolved, but this around it, there is a collection of neutrophils. So the important thing is to note that idiopathic granulomatous mastitis, usually if I have a granulomatous mastitis that is secondary to other causes, the infective causes, the sarcoidosis, all the things that you have mentioned, then I can get this from the history. I can do special tests in the lab. I can do PCR. I can have certain pathological features that are very clear and indicate that this is the diagnosis. But in the end, if I call it idiopathic, to me, the reason is unknown. And the important thing in this is that how do I treat it? I cannot treat it specifically, not like tuberculosis, for example, or when the infective causes is a fungus. Therefore, it is a diagnosis of exclusion. I have to make sure to exclude all this list to make sure that is not something that I can specifically treat. So idiopathic granulomatous mastitis is characterized by the presence of non-necrotizing granulomas confined to breast lobules in which no microorganisms are identified. And the suggestion has been made that disease may be immunologically mediated and therefore analogous to granulomatous thyroiditis and granulomatous orchitis. It can simulate malignancy both clinically and on imaging. The lobulocentric granulomatous inflammation is present usually with admixed neutrophils. Although it's a chronic granulomatous, we get these collections or as you call them, micro abscesses, usually around the fat that has been released by the inflammation that is taking place. It has been postulated that some cases of granulomatous mastitis may belong to the family of IgG4 related diseases or be cases of cystic neutrophilic granulomatous mastitis. Ideally, if I say idiopathic, I don't know the cause. But once I start finding a cause, it automatically goes into the second category of secondary granulomatous mastitis. But until that is proven, we can describe the picture and look for the causes. So if I find the case and I find some from the history, from the clinical history, or from the imaging, that this could be IgG4 related disease. Also histopathologically, I can see some features, or maybe there is previous history with the patient. Then I should do the test and automatically disease is not idiopathic anymore. And the cases of cystic neutrophilic granulomatous mastitis, it is a relative newly recognized entity that presents as mastitis in paras or lactating women, although it has been also described in nulliparous women with hyperprolactinemia. They present the same way with the fever, the leukocytosis, and then the nipple inversion, retraction, and fistula occur, and histologically characterized by, again, a lobulocentric granuloma, the granulomas that often contain neutrophils or area of microabscess formation. And the feature distinguishing this are these empty cystic spaces consistent with dissolved lipid. Now, this is a typical picture, and they have found that in this case, they have identified on a gram stain, they identify bacteria, gram-positive rods, and these are morphologically consistent with corynebacteria. So more and more, whenever you have more information, you have more tests to be done, the idiopathic group will become smaller. So clinical, I think the most important thing, as you mentioned, Sara, is the clinical information and working as a multimodality team to diagnose cases that are actually idiopathic. These are some, the rest of the slides are a few examples, like we have a granuloma of tuberculosis, for example. These are the special cases where we know the cause, it's secondary to something, and they are just as similar like everywhere else in the body. We have granulomas that are, granulomas of tuberculosis are special in that they have a necrotizing center. And this is only a small point or very high point view of the granuloma. Here at the bottom with the star, you can see the typical necrosis of tuberculosis. We call it caseation. And then you have this arrangement of cells that typically line the necrotic area. We have the typical multinucleated giant cells, which in tuberculosis are called Langerhans. And then the epithelioid, these are the epithelioid cells. So a typical granuloma with a necrotizing center, the necrosis is special. It is so typical and pathognomonic that we don't even, when we see this, we say this is tuberculous inflammation. We don't even need to do microbiology tests. or microbacterial tests. This is another special type of granulomatous inflammation. The high power shows you a florid granulomatous reaction, and in this case, it is due to a foreign body. It is due to silicon. There are foamy macrophages because and foreign body giant cells. These are multinucleated giant cells, and we call them foreign body type. We have foamy macrophages. These are the foamy macrophages, and they are engulfing the silicon, the foreign material. So another typical form of granuloma with a cause. In this case, a foreign body reaction granuloma. This is an example of diabetic granulomatous mastitis. So in this case, you have the history and all that previously that comes to, of course, you need to exclude. It could be anything else. As you said, clinically and radiologically, you will have to differentiate eventually on biopsy. In this case, it's a core needle biopsy. You can see that the architecture of the breast is preserved, but there is inflammation. And on high power, you can see the granulomas. They don't have a caseating center. This is another view from another area. It shows you the multinucleated giant cells. Here we just have a granuloma, the epithelioid cells. Here you have another site shows you more granulomas, and these granulomas are containing multinucleated giant cells. You have to put all of this with the history together. In this case, I think, especially in diabetes, you would love to do a TB test. The granulomas are not typical, but it is not essential for the granuloma to be pathognomonic. So I think in diabetes, we would love to exclude other causes of like tuberculosis. Now, this is another cause of granulomas, which are which is sarcoidosis. They have typical granulomas, but they don't have these necrotizing centers. They don't have the Langerhans giant cells. Usually they don't have multinucleated giant cells, but like in this focus, you can have a few multinucleated giant cells. The interesting thing in this is this last picture, the number C, is from the lymph node. And these two are from a patient with, here we have typical granulomas, but the interesting thing are these. And here in the higher power, this is an infiltrating carcinoma. So it doesn't exclude it. And histopathology, we have to look at all the tissue. So we do have the typical granulomas of sarcoidosis, and this would come from the history of the patient. Maybe this is the first diagnosis. So typically we'll have to exclude that this is tuberculosis. But the interesting thing is when we do pathology, we want to, especially with the clinical and radiological features of this condition, we want to exclude malignancy. In this case, they were both there. And this is another example. This is different. Now, this is not sarcoidosis, but this is carcinoma initiating a reacting inflammation, which is granulomatous. And this is even more interesting. You can clearly see the malignancy. But here you can see all the field is malignancy, but you have a reaction, an inflammatory reaction. The usual inflammatory reaction is a lymphoplasmocytic infiltrate around the tumor. But in this case, we have a typical granulomatous reaction with multinucleated giant cells, and it is in reaction to malignancy. These are the references I have used, and thank you. I'll stop sharing.
Okay. Thank you very much, Mrs. Nadia, for this nice elaboration of the granuloma. So we'll continue. Do you see my screen?
Yes.
Yes.
Yeah, okay. So as we say, from the clinical symptom and signs, you will suspect that the patient who had a multiple incision, who came with painful erythematous lump, you will suspect granulomatous mastitis. You do the imaging and you discuss with the radiology people, then they will ask you to take a biopsy, and then Nadia nicely elaborating what is the finding in the biopsy. So usually when the patient present, they can present in one of three ways. Either they come with an abscess which is opened, or multiple abscesses that has been opened, and then they will come and to consult you. Because of discharging sinuses, and then you do the radiology, you suspect granulomatous mastitis, you take a biopsy. Or they present with multiple masses, not yet forming an abscess, and then that will be a dilemma with the radiology. You take a biopsy, and by the time the biopsy result come back, usually the patient come before that with an infected, making an abscess or already forming an abscess. So again, it will be you're suspicious about the mastitis, or they
May I
will
ask?
present with
May I ask? Usually, how long do they have the disease when they come to you?
usually, as I say, I mean, if they have like a disease for a while, they went to several surgeons, drain, open, they usually like 2-3 weeks when they come. Or they come with a mass which is formed for the last 1 week, becoming painful. They start with a mass, then become painful, and usually like 1 week. Or they will present with an abscess. They also, again, this abscess not happening like immediately. They have the lump and then infection, and then take about like 7 days, 10 days, and then they will present with abscess. So if they present with a mass, we take a biopsy. If they presented with a different discharging sinuses and a small collection, again, we'll drain the small abscess and take a biopsy. Or if they present with a large abscess, then we go and open and we take a biopsy from the wall. And I think this is very good here to mention for the surgeon. If you have an abscess and you're suspecting granulomatous mastitis, you better open and take good biopsies from the wall to help the pathology people to get a proper diagnosis.
Yeah, deeper.
So, yeah. So, where are we? Yeah. Okay. So the management, patient came back. So the histopathology, usually Nadia nicely elaborating and make my management plan very easy. So we can either get that this is an idiopathic granulomatous mastitis, or it is a tuberculous granulomatous mastitis, or mastitis, chronic mastitis, non-specific chronic mastitis.
Or a diabetic.
What to do? Or sorry?
Or a diabetic.
Or the diabetic. So if we diagnose an idiopathic granulomatous mastitis, the treatment is to start with the steroids. Okay? If it is come like atypical bacteria or tuberculosis, then we'll give the antituberculous treatment immediately. So I will go through the management plan for these cases. So the treatment often depends on severity and recurrence. Corticosteroids are the ministry of reducing the inflammation. So if the patient presented with idiopathic granulomatous mastitis and there is no infectious agent and we don't think that is tuberculous, we usually start with corticosteroids. And the corticosteroid we give them for at least 3 weeks. and you can continue for a month or a month and a half. It's not like giving it for a week or so. It will not cure the disease. So usually, at least you should continue for 3 to 6 weeks with the corticosteroid. You give a high dose and then you taper it, and then you continue for like 3 to 6 weeks, depending on the response. The treatment with corticosteroids, from our experience and the cases we see, is usually we have a high rate of relapses, and the response is not that good in most of the cases. What we do is the other one is the surgical option. I mean, you corticosteroid, you give it when you have the inflammation, and you took a biopsy. It is coming as idiopathic chronic mastitis. There is no abscess. You continue with the treatment. If you develop an abscess, usually we advise minimum intervention, because you open an abscess, second day you'll have another abscess, you'll have another abscess. If they are small, you just aspirate them. You don't go and do multiple surgery. If you do incision, you incide them, small incision, curette, and depend on the treatment to take the rest of the for the management. Okay. People are talking about, if the steroid is not working, you can go second line to methotrexate, the immunosuppressive agent. And nowadays there is papers advising using them both, the corticosteroid and methotrexate, and they claim a better response. So the first line, the corticosteroid is the first line treatment of idiopathic granulomatous, reduce the inflammation. The doses are tapered based on the clinical response and side effect. High failure and relapse rate observed in some studies, and in our cases we see a lot of relapses, and you have to use them for a long time. Surgical manager, I say just incise and drain wide excision if the abscess is big. If the abscess is small, just aspirate and give the treatment. Okay. Recurrence, as I say, is common and require close postoperative follow-up, and they usually come with multiple recurrent abscesses. If you give the steroid, then that will decrease in most of the cases. Now, methotrexate as immunosuppressive is used in second-line treatment in steroid-resistant cases, act by modulating the immune response and reducing granuloma formation. It is administered in low weekly dose to minimize the side effect. While combination therapy, as I say, some people claim that it had a good response. So again, methotrexate, you should give it for like at least 3 to 4 weeks to get an effect on that. So antibiotics, if it is infectious and the patient came with abscess multiple times, and you take a culture and a swab and you find that there is a gram positive, gram negative, whatever, then you can add antibiotics to your treatment. So cultural sensitivity is important in most of the cases to do that. Emerging therapy, now people are talking about using biological agents like tumor necrotic factor alpha inhibitor, and their investigation targeted therapy and immunomodulator. This is too much, I think, for my opinion. This is too much, given these therapies, very expensive, and with really, really very bad side effects. I wouldn't advise people to go for that. So what is our experience? I came back to Sudan in 2004, and at that time I have like 2 cases which came with this typical history I told you about. And when you took a biopsy, it came back, luckily for us at that time, it came as tuberculous granulomatous mastitis. So we give tuberculous treatment, and we use the fixed dose combination therapy, and that is the antituberculous. They are putting all the drugs in one tablet, like INH or rifampicin and all that is a combination therapy. One tablet contain all the combination therapy, and it is supplied by the American agency for free. It's very expensive drug, and it's what was supplied to Sudan as a charity treatment, and it's given free for people with tuberculosis. So I sent these patients to that center, and they give them the tablets, and amazingly, they respond very dramatically. In 2 weeks, all the symptoms disappear, and in 1 month or 2 months, they completely resolve. and we continue for 9 months like the normal treatment for tuberculosis. So any patient came with granulomatous mastitis with confirmed diagnosis of tuberculosis, and as Nadia say, we don't do like the culture and thing. They usually tell us the histopathology. This is a tuberculous granuloma. So we just start the treatment for that, and we send them, and these people, they accept that they have to have a diagnosis of tuberculosis. Since then, we have several cases of the idiopathic type, which we're giving the corticosteroids, and they are not responding well. And they came with recurrence, every now recurrence. So we said, okay, why not? Let's try the anti-tuberculous in this group of patients. And we did. And they respond very well. Even the idiopathic ones, they respond very well to the treatment. And again, amazing results. So we now every patient who had an idiopathic, which is not responding, we start with corticosteroid for the idiopathic one, which is not responding to the corticosteroid, or they have to take the corticosteroid for a long time and they have recurrent relapses, we give them the anti-tuberculous and they respond very well. We have
But
like 100%.
Did you revise pathology?
Usually not. But usually we have,
because I'm sure
like,
some of these cases are tuberculous.
maybe.
For
Anyway,
definitely.
because we have like, usually you know me, I have to contact the pathologist and tell him what you find, do you think it is tuberculous? And most of the time they said no, we're sure that it's not a tuberculous and this is a idiopathic type, and so we took that.
The immune response, the inflammatory response that happens depends on the immune status.
Okay.
So forming typical granulomas is good in a way, but it depends also on the immune status of the patient and how he's reacting. And of course, the tissue that you get.
Yeah.
So you can miss the granuloma or the typical signs. To have a response.
I mean, we have a lot of cases. I mean, most of our cases, the one I saw, it couldn't be like all of them are tuberculous. So they must be, the anti-tuberculous definitely had a role in modulating the inflammatory response. And I have a strong belief that this is the way it modulates the anti-tuberculous combination, especially the combination therapy. They modulate the inflammatory response, whatever the etiology is. So that's our observation. I think we have to look into that, deeper into that, as Nadia said, to revise the histopathology. But the usually response, the treatment usually, if it is tuberculous, we give it for 9 months. If it is an idiopathic, we give it for 6 months, and they respond very well, and we have like a 0 recurrence rate. They respond within 2 weeks, and complete resolution usually occurs in 2 to 3 months. Unluckily, we lost the data during, I'm collecting the data in Sudan, but hopefully we can get it back. Most of the people, we give them the anti-tuberculous, they resolve completely the skin edema, the sinuses, everything. The breast went back to normal after a few months, and it is amazing results. So close follow-up is crucial to detect relapse early, because these cases, I said, the relapse is very high. Regular clinical evaluation and imaging is needed. Monitoring for treatment side effect, especially from steroid and immunosuppressive or the anti-tuberculous. I tell you what, I have, like we said before, we have lactating women, we stop the lactation when you give them the anti-tuberculous, and we have pregnant women, and it was very safe. I mean, I was worried, I mean, giving this anti-tuberculous to pregnant women, and they're really suffering, so I have no alternative, but I gave it to them, and luckily we don't have any side effect from the anti-tuberculous, even in pregnant women. The patient education and on recognizing early symptom and recurrence, collaborative care involving surgeon, radiologists, and pathologists is very important to deal with these cases. As I said, the prognosis depends on whatever treatment you're giving. I advocate the use of anti-tuberculous in both idiopathic and tuberculous for the non-responding cases. And challenging management, diagnostic delay due to mimicking of malignancy. Usually the people, they take long time to reach a diagnosis, especially as Sarah said, mimicking the malignancy, lack of standardized treatment guidelines, and high recurrence rate despite the therapy, and potential side effects from the long-term steroid and immunosuppressive. I think advocating the use of anti-tuberculous will solve a lot of problems. Access to advanced imaging and biopsy resources was limited setting to diagnose the granuloma, what type of granuloma, and what type of causative agent. I think that need a very experienced pathologist to do.
Sorry.
In summary, granulomatous is a chronic breast condition characterized by chronic inflammation and granuloma formation, multifaceted etiology involving immune, hormonal, and infectious factor. Management require a tailored approach based on clinical presentation, and advancing diagnosis and therapeutics are improving the outcome. Thank you very much. So now the floor is open for questions and discussion.
Thank you, Mr. Omer, and thank you, Dr. Nadia, for this nice presentation, nice information. صراحة يا دكتورة نادية احنا كنا معتمدين على الهيستوباثولوجي انه يحسم لنا الموضوع في الجرانيولوماتوس ماستايتس، لكن still حسينا ايوه it's not that pathognomic still يعني.
No, you have to look at the picture and to look at the pathology, the tissue that you have on the background of the clinical information and radiology.
Yes,
and you have to look at the tissue that you get very carefully. The last two slides show you that sarcoidosis, a granulomatous condition. The patient has sarcoidosis, but there is also malignancy in the background. And the last one shows you the other way around. Malignancy itself has an inflammatory response. And in this case, this was a granulomatous reaction. So looking at the tissue very carefully is important on the background of clinical and radiological information. Everything that comes with the specimen is very important to interpret what you see.
And usually, most of the time, after you see, you always have, when the patient come back to you for the follow-up, and you see that still there is skin edema and there is body orange sometimes and nipple retraction, you always worry that there might be a carcinoma. But
in the
what
background
happens when you give the treatment and they improve, this is the reassuring thing. When the breast coming back to normal, the edema subside and thing, with the treatment, then you say, okay, now I'm
so you need to do the follow-up and you need to recheck them clinically and by radiology. Once the inflammation subsides, what is the remnant? Maybe you need to take a biopsy from a different area.
That's right. It is always a multidisciplinary.
If it's a core biopsy, of course.
Dr. Muna.
Assalamu alaikum.
Assalam.
First of all, I would like to say thank you so much for all of you, Mr. Omer, Sarah, and Nadia, for very informative presentation and giving insight about very difficult topic, which is granulomatous mastitis. As you all said, it is rare, but it is benign, and it is very difficult to diagnose and very difficult to treat, especially idiopathic. And so far, I have seen 2 patients here in UK, and both of them, they are from Asian origin, from Pakistan and Bangladesh. I don't know, this I think confirm the role of genetics in the diagnosis. And I think I don't want to add anymore because you elaborated in a lot of very informative information and the way to treat and everything. And I would like to, first of all, I would like to say to Mr. Omer, it is very interesting to see or to know that antituberculous can work in idiopathic granulomatous mastitis.
That's new.
Yes. Because so far, recently I have a patient which is she's pregnant and she got a granulomatous mastitis, and we tried high dose of steroid. Is not settling. And just to mention that, in addition to steroids, methotrexate, and antibiotic, if there is abscesses, as they mentioned in the book, there is a role of surgery, which we don't encourage at all. So we do our best to avoid surgery. It is mentioned we can do a local excision of the masses. Even we can go up to mastectomy, which is quite debilitating for ladies, just for benign disease to have a mastectomy. So never seen surgery done for granulomatous mastitis. We do our best to do conservative treatment, but it is difficult to treat. It takes ages to settle. And I think that's it I would like to say.
Thank you.
Thank you.
That's very interesting about the anti-tuberculous treatment.
Yeah.
Wallahi, Amuna, it is always, see, they have a, this is the kind of patient I'm talking about.
Yeah.
The diagnosis is idiopathic and you give all the modalities and steroid for a long time.
It doesn't work.
and
Yeah, I
they
know.
are suffering. So we gave them, you will be astonished with the response. We will be astonished with the response. In a week or two, the inflammation stops and the patient feel much better. And in a month, everything resolves. You'll find
And-
the breast, no edema, no body
nice.
urine, no retraction, everything stops.
And can you use it with pregnancy? Because so far I have a pregnant
Yes.
lady, young
This is
lady.
what I said.
Yeah.
This is what I said. We used it in a few patients who were pregnant, and I was worried, but we didn't see any side effect from that.
All right.
Nothing.
And how long you
Yeah.
give it for pregnant ladies, anti-tuberculosis?
I give it for minimum 6 months.
6 months. Okay.
6 months. If it is idiopathic, I usually stop at 6 months. But usually you see the response in 2 months. I didn't know. I said, okay, because I know there is a high recurrence rate, I usually continue for 6 months just to, as Nadia say, in the case that it might be an underlying tuberculosis. So I continue for 6 months. But after 2 months, everything resolves.
Okay.
I don't know if you can stop at 3 months. I don't know. But
Oh, well.
our practice here, I usually take it for 6 months.
You know, if I were in SOBA now, I would ask you for the cases to check.
I hope I'll get them.
Alhamdulillah.
I will get them.
You know, we got video, and funny enough, the room, we have a room upstairs in the lab where we have recent records. Nobody went into it. They could see from the door that it is just blocks and files. They didn't go into that room. But I'm hoping that it's all
Very
there.
nice. Inshallah. Inshallah.
Inshallah.
Very sad. Very sad what is going on and losing
Yeah.
a lot of things.
Alhamdulillah.
دكتورة
you have
Yeah.
a comment?
ممكن أنا I have no hand raising icon.
أنا أفتش
حق الفيتو يا ليك حق الفيتو طوالي تخشي.
أول حاجة يعني thank you very much Mr. عمر, دكتورة سارة, دكتورة نادية يعني for the informative lecture and interesting discussion. We enjoy it really يعني. Regarding granulomatous mastitis, يعني as you said, it is challenging for the clinician, for the radiologist and pathologist, as we understand from Dr. Nadia. But for us, for me, I have seen a couple of cases, you see, outside Sudan. And I have seen يعني 1 or 2 cases in Sudan. Okay. For me, I suggest or I raise granulomatous mastitis in my differential diagnosis in certain conditions. You see, radiologically. When I have seen, when I see multiple abscesses interconnecting, if I have seen interconnection between these abscesses, I will put granulomatous mastitis number 1 in my differential diagnosis. And if the abscesses demonstrate also multiple tracking to the skin, you see, or branching tracking, okay? This is, or large size track to the skin or to the nipple. Then I raise granulomatous mastitis, and most of my cases proven to be granulomatous mastitis. This is regarding ultrasound. And ultrasound is superior to mammography in the diagnosis of such cases. Okay? Yeah, because usually, most of the cases on mammography presenting as asymmetry, as Sara said, rather than masses, but sometimes can be even it is a strong mimickers for breast cancer, because even can present with a speculated mass.
Yes.
Okay, and as she has mentioned, can be presented like an inflammatory cancer, and the lymph nodes, there is overlap between the malignant and inflammatory adenopathy. But sometimes it is really challenging. But one tips also, I start discussion before we start this lecture about one case I have seen in Sudan. And it was extensive involvement of the left breast in a young lady, 40 plus. She was pregnant. And as Mr. Omer said, and it is strongly related to prolactin. Okay, and that is why usually I'm seen in the around pregnancy and lactation. But usually I ask the lady about these things when I suspect granulomatous mastitis. And that case was a pregnant lady, 40-year-old pregnant lady. Clinically, she had, as Mr. Omer said, she had no constitutional symptoms, presented with just breast pain and enlargement. And it was simulating inflammatory cancer because it was rapidly progressing, and the breast enlarged, and so a lot of, and they had taken biopsy, was inconclusive. You see the biopsy sent to me to re-evaluate the patient with ultrasound. And I have seen Tertil here. She can ask her colleagues. She was not with me, but her colleagues, Amal and Sumaya, were with me. And I told them, yes, it is not a mass. This is infiltrative process involving most of the left breast, non-mass-like lesions, okay? Involve the whole breast, hypoechoic and all, and hypervascular, but there was tip in that case that the background structures of the breast was preserved. It was preserved. I told them this is a most likely 99%. It is an inflammatory process rather than a neoplastic process. If it is neoplastic, it will be lobular carcinoma. If it is neoplastic,
yes.
but the chance for neoplastic is less than 1%. To me, it is an inflammatory. Okay, and at the end, they had taken excisional biopsy, and it was proven to be a granulomatous mastitis. This is regarding ultrasound. MRI, yes, MRI, it is important. Usually we recommend MRI, not to, rarely for further characterization, but most of the time we recommend MRI to evaluate for this extent, as Dr. Sara mentioned in her presentations. And then in MRI, usually it is non-specific, as she mentioned, but some lesions, okay, that we can raise possibility of granulomatous mastitis or support the ultrasound findings to be granulomatous mastitis if it is a strongly or hyperechoic on T2 and demonstrate ring enhancement on post-contrast study. Sometimes restricted diffusion of the content, not on the corresponding to the rim of enhancement. This is can differentiate for us between an inflammatory or an evolving abscess versus a malignant mass. The malignant mass, the restrictions corresponding to the enhancing rim, while it occur as a reverse in the case of inflammatory, the content within the lesion giving restricted diffusion, not corresponding to the rim of enhancement, and also can present as clustered ring. Okay, يعني rarely extensive inflammatory or non-inflammatory invasive cancer can present as cluster ring, but most of the cluster ring we have seen were granulomatous mastitis. Thank you very much.
Thank you.
Thank you.
دكتورة سلوى.
دكتورة سلوى اتفضلي. You can unmute.
السلام عليكم جميعا.
عليكم
سلوى
السلام.
ازيك؟
كيف الأحوال؟
يا
شكرا جزيلا
مرحبا.
مستر عمر، دكتورة نادية، دكتورة سارة for the informative lecture. For the although rare and difficult topic for diagnosis, especially there are many differential diagnoses of granulomatous mastitis. And as mentioned, I would like also to agree with Nadia that it depends on the biopsy, because this is a core biopsy, and it
Usually.
usually it is interesting that to know that antituberculous can work with idiopathic granulomatous mastitis. Maybe it depends on the site of the biopsy itself. Maybe if you took another biopsy, it may show the frank tuberculosis. And I think if there is time for reviewing cases, I think in the future, one has to look again for the biopsy or take another biopsy so that we can make sure these are not
And do
idiopathic.
PCR.
Yeah, these are not
And
idiopathic.
even, do you think the atypical mycobacterium can also be because they can be treated with the antituberculous? So the atypical mycobacterium, I mean,
Yes.
Yes.
One
They
one
are
of the cause,
available.
yes.
They do occur. Yes.
Yeah.
as a cause.
Very interesting.
one point يا مستر، برضو مرات أنا البيشنت بتجي يعني بسألها في الهيستوري، بيكون عندها زي الفليتنج ليجنز، يعني تجي تقول لي المرة دي جاية برايت بريست، next time حصل له هيلينج وتجي في يعني يعني لما تجي واقول لها يعني جايه مثلا بون سايد، اسالها هنا involved هل عندها نفس الليجن كان في the same or the other breast، مرات القى عندها في other breast كان قبل فتره involved و completely healed or partially healed وجايه بالother side.
عشان pain.
This is a typical history. المريضة تجيكي، هو طبعا اغلبهم بيكونوا في one side، لكن بيجي زي ما قلت ممكن بالبوث سايد، لكن اغلبهم بيكونوا في one side. لكن
لا ما يعني one side يعني مثلا بيكون حصل له هيلينج
بعد فترة.
ايوه this is typical. عشان كده تجي تاني بعد شوية. مرات ناس يكونوا عملوا 5-6 سيرجريز، كل مرة
صح.
2-3 يفتحوا لهم واحد، بعدين بيظهروا سريع جدا جدا، بيظهروا سريع جدا جدا. يعني انت بتعملي واحد وتدي الانتي بايوتيك كده، من تجيكي بعد 3-4 يوم يكون الثاني ظهر.
ايوه
quick.
بالضبط كده. ما انا قلت لك فعلا نحن هسه يعني وي سجست الجرانيولوماتس في الراديولوجي لما نزال في الهيستوري، يعني نزال في الهيستوري تقول لي انه كان في واحده هنا يا القى باقيها لسه ما هيلد كومبليتلي ولا بارشالي هيلد، ولا قبل ما هي بدت ظهرت في حته ثانيه ويبدوا بعد ده ظهرت الثانيه وظهرت الثالثه، ويبدوا بعد ذاك بيحصل بيناتهم انتركونكشن. راديولوجيكالي القى tracking between lesions دي highly suggestive. highly suggestive. Radiologically typical of granulomatous mastitis.
كلينيكالي ده.
عايزه اسال بس دكتوره ناديه يا جماعه لو سمحتوا.
اتفضلي.
دكتوره ناديه عارفه انه التوبركلوس بتكون كازيتين جرانيولوما، ودي بنعرفها من البايوبسي صح؟ لكن في نون اسيد فاز باسيلاي مايكوبكتيريوم ده ممكن برضو نعرفه من البيوبسي ولا we need culture, because I know we need الculture برضو prolonged culture for mycobacterium is important. What about a non-acid fast bacilli mycobacterium? What we do?
Yes, you can have the Selwa, you can share. You don't have the typical caseation, and from the biopsy, we cannot tell for sure what type it is. Different types have different extent of caseation, and it is multifactorial because it also depends on the patient's immune status and response.
Yeah.
So if we have to take it like this. If I find the typical granulomas, I can, and I know this is happening like in Sudan, the most common is Mycobacterium tuberculosis. So I know this, I call it tuberculous lymphadenitis or tuberculous mastitis or kida. And I find it anywhere in the tissue. Whatever tissue comes to me, I can see.
Yeah.
I have to take it in the area where I am. It's not just everywhere. No? You have, if I find it, like say in Europe, I don't know how common tuberculosis is in Europe now. If I find the case, it is common.
It is not common. It is usually it is in ethnic minority, for example, people from other backgrounds, from Asia or Africa, and
okay,
and with recent travel to these areas.
Yeah, okay. So you have to take it in your background how it is, and if I find the case here, I will have to trace it, like I'm talking in Europe. In Sudan, we don't go for PCR and things like that, normal tuberculosis cases, because of the typical what I find in a lymph node. If I suspect it, and if clinically it is suspected, and I don't find the typical features, I will suggest it in a comment that this case better goes for PCR if it's clinically indicated and you are still thinking of tuberculosis. It could be that the biopsy I got or the reaction of the patient is not typical or not advanced enough that I can recognize good granulomas, or my biopsy doesn't contain good granulomas, and I haven't seen it. But it doesn't exclude tuberculosis if I don't find it.
Yes.
Also, it depends on the biopsy itself. Sometimes you don't see the typical granuloma.
Yes. Selwa, answering the question, other atypical mycobacteria, if they cause
non-acid fast bacilli, can we diagnose them from biopsy, or we need culture, microbiology and culture? This is my question.
But the culture, it will take months to have the result of this culture. Yeah, and usually the Nielsen stain usually in tissue is the sensitivity
is very difficult.
It's very low. Very low.
Okay.
يا منى الكيسز بتاعه ديل هم ethnic minority فالسسبيشس اساسا السسبيشس بتاعه انه ممكن يكون tuberculosis ولا atypical فاعمل لهم PCR في التيشوز.
It's better.
والله هم البيوبسي قال suspicious of granulomatous.
شفت granulomatous دي حوالي تقديم انتي توبيركل هيبقوا كويسين.
ده اللي بنعمله في السودان.
البروتوكول بتاعنا بده empirical انتي
يس في البروتوكول عندنا في السودان نحن بندي تريتمنت وبنشوف الريسبونس.
عشان اندمك السودان عشان اندمك والتوبركلوز.
عشان اندمك.
هنا I have to have a justification to give anti-tuberculosis.
Yeah.
لكن if you go for it, give them the
trials for the diagnosis.
Yeah.
In Europe, I don't
tell them
think
about
it's
experience.
Maybe we'll see. Okay, thank you for the answer. Thank you so much, everyone.
I hope it clarified it.
Yes.
أنا ما فهمت الإجابة بصراحة. أنا منتظرة إجابة منى وما فهمتها. هل ينفع البيوبسي ولا you need culture?
To determine the type, you need PCR.
need.
Because الculture it takes time.
يعني يا نادية لما تشوفوها كازيتنج جرانيلوما ممكن تكون tuberculous or non-tuberculous?
لا, tuberculous.
Tuberculous.
If it is the nice scenario, the beautiful one would be if I have a well-formed granuloma with central caseation and the Langhans giant cells. طوالي أنا بسميها tuberculous lymphadenitis
So this is
or
tuberculosis.
tuberculous inflammation. Yes, because it is, as I said, it's in the background. We do have it. It's an endemic country.
طيب
And we have in the protocol that you give empirical treatment. So having the diagnosis is just the best scenario.
When you suggest to go for culture?
We hardly do that. The next step, if we need to determine it, it would be PCR.
Okay.
Yeah.
Which
Rayan,
was available.
Yeah.
Rayan is asking, after how long can I shift from steroid to methotrexate or decide the
very
surgery?
interesting.
Yeah. So as I say, you start with the steroid for at least 6 weeks to see a good response. But while you're doing that, after 3 weeks, if the patient is not showing any response, if they're showing response, you should continue for at least 6 weeks. If they are not showing response after 3 weeks, I think you could shift to the methotrexate. And now, as I told you before, there is a paper came that the combination of both, I mean, if you are doing the steroid and the patient is not responding, then you can add the methotrexate with that. But I would be cautious doing that. So I will advise, if you have the steroid for 3 weeks and you don't have a response, then shift to methotrexate.
Did you use it before, mister? Did you use this combination before?
No, I wouldn't do that. This is for answering our question. If I use the steroids and the patient is not showing response after a while and showing relapse and another abscess, I think I shift to antituberculous immediately.
And I did answer the question about the surgery, Jan, early. I said we don't oncologic surgery for granulomatous mastitis because it causes deformity. And unless there is an abscess, it's better to be radiologically drained, but surgery sometimes indicated just to drain the abscess, but we don't oncologic surgery. It's a last resort to treat it unless it is very, very severe and very, very bad and difficult.
Small abscess, aspirate under radiology.
Yeah.
Unless it's a really huge abscess, then you go for surgery. Or you want to take a good biopsy, then you do under local, open it. You don't have to do like big incisions. Just open it and take biopsies from it.
Well, here we ask the radiologist to do the biopsies for us. Sorry.
Better, because we can see.
Sometimes,
we can decide the area, the best area for biopsy.
Yeah,
it's true.
Yeah.
I mean,
and then you don't need two consultants in the same area.
Multiple tracking. مرات بيكون extensive tracking. فبيكون الاسبريشن شوية difficult.
Yeah. صح.
It is. ما أنا قلت لك if you don't, usually even with all these abscesses and the drainage and discharge, if you give the treatment, the antituberculous, they all dry up. They all dry up. You will just left with a small thing with local anesthetic, sometimes aspiration.
Interesting.
Yeah.
It is like the cold abscesses. When with antitubercular, everything resolved.
Of course, you have remaining fibrosis, and may I add here, the radiologist said speculate, which makes it more like malignancy. And this is typical. We get calcification in the fibrotic tissue, the scar tissue.
Yes,
and we get a degenerative change, which is calcium deposition, calcification.
Yes.
So these are the speculated
speculated mass with calcification. You are right. Yes, it occurs.
This is referring to the fibrosis that is happening in this long-standing chronic inflammation.
Yes, it occurs. Yeah, it occurs sometimes. Not typical, like it occurs and make it more challenging.
Yeah.
Usually they present early. It is between acute and chronic, in between. So most of the time they present like a week or 10 days or something like that, and then you start the treatment. So they have really, most of them radiologically, they have a complete resolution of the radiological changes.
Yes, that is why most of the time mammographically appear as just an asymmetry.
Yeah. اوكي.
معي سؤال. السلام عليكم.
هاي
عاملة ازيك؟
سلام.
كيفك يا دكتورة نادية؟
تمام الحمد لله.
كيفك يا دكتورة سلوى؟
سلام خاص بالباثولوجيست بس يا آمنة، احنا ما علينا سلام.
بقول أرد ولا أسلم عليهم كلهم، والله كلهم أسلم عليهم. دكتور عمر كيفك يا دكتورة منى كيفكم كلكم؟ وكيفكم برزنتنج جميل. دكتورة سارة برضو أنا بسأل في إنه الدول دائما انتم شو قلتوا النقاش كان عن ان هي توبركلس. اذا كانت هل في رول للاستيرويد؟ هل انا ممكن ادي استيرويد اول وانتظر الريسبونس بعد ذاك اقوم ادي يعني الروم بتاعت التوبركلس؟ الاستيرويد الرول بتاعه في موجود ما زال ولا في التريتمنت؟
انت ما دخلت
يعني
من الاول ولا شنو يا امنه؟
هي ما كنت في الاول صراحه كنت
اوكي
في
اوكي. لا نحن we said that
typical.
اذا كانت tuberculous we give the
ها.
antituberculous. لكن اذا كانت idiopathic we start with the steroids, and if the patient after 3 to 6 weeks not responding very well ولا relapsing, then we'll consider the second line either to go for methotrexate, which is the standard now. لكن نحن we don't do that. بعد الاسترويد if they're not responding we give an antituberculous. لكن you can try بعد الاسترويد الميزوتريكسيت ده second line في الجايد لاينز.
حقه
يعني انا
التجربة
سؤالي
اللي
ما
هي
الفيرست لاين.
مستر، حقه
نعم.
التجربة.
Sorry what you said؟
يعني انا قصدي ما
ما
هو
فيش.
الفيرست لاين، انا سؤالي هل هو الفيرست لاين ولا انا طوالي
لا
ببدا
ما هو انت ديبند على الدايجنوزيس. اذا جابوا لنا ناس الباثولوجي من الاول جابوا لنا والله this is a tuberculous granuloma
نديه treatment.
suggestive of tuberculosis we'll start طوال الانتي tuberculous treatment. ما في داعي تو ويست. طبعا الاسترويد برضه عندها رول في التوبركلوز انفلاميشن، بتقلل الحكايه.
هو بيولوجيك. انا بس
كان
سؤالي شكله سؤالي ما واضح. ها
لا اذا توبركلوس بتبتدي طوال انتي توبركلوس. لكن
ما
كان
اذا
جاتك
توبركلس
الايديوباثيك،
توبركلس ايوه
اذا جاتك الايديوباثيك اللي هي ما توبركلوس فالستاندر انك تمشي بالاسترويد في الاول، والاسترويد اتليست فور 3 to 6 weeks. اذا ما في ريسبونس ولا ريلابسنج بعد ده ولا كده فممكن يو جو فور الانتي توبركلوس.
ايوه.
يا مستر حصل لقيتك ساركويدوزيس ولا فاجنرز ولا كده؟ انا غايته بصراحة ما لقيتني في البريست في الاكسبيرينس. انا ما لقيتني، انا ما لقاني.
You have to include it because it is the differential of granuloma.
Yes.
No.
انا لقتني حالتين تي بي، بريست tuberculous mastitis، ولاقوني يعني couple of cases بتاعت idiopathic granulomatous يعني presenting in different ways.
هي طبعا ما كثيرة، لكن as I have read the literature you confirm دكتور عمر it is increasing, it's on the increase.
ايوه لا اتيز حتى في السودان عندنا. شفت انا يعني هسه وصلت لمرحله، طبعا الناس الباثولوجي حيزعلوا مني، انا مش حيزعلوا لكن يعني
قول.
من الدوني يقول لي والله كرونيك انفلاميشن ليمفوسايت وماكروفيج هنا ما في جرانيولوما، نو جرانيولوما، بقوم ببتدي بالاسترويد. كان قالوا جرانيولوما كازيتنج ما كازيتنج، بس كلمه جرانيولوما دي موجوده طوالي ببتدي بالانتي توبركلوز.
دي جاب
يعني
السؤالين
you
من قبل
don't
بس
rely
ليه؟
on pathology
دي
يا
جاب
دكتور
سؤالي.
عمر.
لا بس هم انا ريلاي اون. كان
يا
قالوا لي
الرلاين
جرانيولوما
على الهيست ان انت
بس شفت كلمه
سؤالين تبدا
جرانيولوما
كيف؟
دي كان كتبوا لي ليمفوسايت وماكروفيج وما عارف شنو، بس برضه الماكروفيج برضه بنلقى ماكروفيج دي طوالي بقبل
لكن
مع التوبركل.
الجرانيولوماتس الإيديوباثيك هو ما تبركلس وفيه جرانيولوما بس ما فيه
ايوه
كيزيشن،
بالضبط كده.
ما في كيزيشن.
لكن اغلبهم اللي بيخليني ابدا في الاسترويد من يقولوا ما في جرانيولوما، يقولوا والله في كرونيك انفلاماتوري سيل ليمفوسايت وكده
steroids.
لا لكن
You start the
let's
treatment
be
according to
scientific.
the pathology report.
Let's be scientific. If it is granuloma and they propose that this is most probably tuberculous, you start with antituberculous. If they propose that this is not a tuberculous to start with, then you give a steroid to start with.
طيب
والله
accepted
من الكيس ده، من البرزنتيشن ده ممكن او انتوا اكتوا تطلع بيبر يعني. هتكون
والله
very
انا
interesting
زعلان
paper.
انه نحن البيبر دي انا من 2004 بتكلم وبقول للناس كده وما كتبناه، وبعد شويه طلع واحد من مصر قال انا بستعمل واحد ريفامبيسين وقال عنده جود ريزلت. ده سنه بعدنا بخمسه سته سنين، وبعد شويه طلعوا الهنود من سنه 2012 عملوا لوت اوف بيبر في الانتي تيوبركلوس جرانيوتوس ماستايتس. والله لحد هسه ما ظهرت في الدسكشن في الليتريتشر في اليوروبيان كوميونتي،
ما
لكن في
لقيتها.
a lot of papers من طلعت من الهنود والجماعه دي بعد 2012. نحن بروبوز من 2004.
ما
فالغلط بتاعنا نحن انه ما كتبنا، ما
هم
بنكتب
عندهم
في
كثير
ايوه ما بنكتب.
tuberculosis.
بعدين ما الا تعملي. انا الحاجه اللي اقوله هسه اللي عرفتها ما الا انت يعني you can just send
كيس ريبورت.
editorial case report ولا بس send your
letter to
opinion
the
to the
editor.
editor.
أيوة.
letter to the editor say انه انا والله
ايوه
يا جماعه انا كده واستعملت كده، خلاص تثبت حقك يعني. ف
هي طبعا هسه بقت شغلها بالريسيرش جيت دي، بتلقى الجروب قاعد، فانت بتلقى لك جروب، والجروب بيكون في توبيك، فانت بتقول والله انا انترستنج بماي مثلا بدiscussion الكيس نفسها هم فورموليتنج، فبتطلع البيبر وبيطلع اسمك في البيبر يعني. This is بقت
صح.
one method الناس بقت شغاله بها وبقت very popular في ناس الريسيرش جيت
أيوة.
عندهم ريسيرش جروب. ايوه فبتلقى انه بتلقى
والله
شغلك
سنت
ذاته عشان
التكنيكال
يعني
كان
لان
في بس
حاجات مهمه الكلام
يسال.
ده وفيري رير.
اي والله الواحد بيزعل
ايوه
يعني
انه الفيرست لاين
تشوفي.
انا جبت سؤالين، والفيرست لاين ديبند اون ذا هيستوباثولوجي ريبورت. فانت الفيرست لاين
ايوه
بتبداو بالاستيرويد ولا بتبداو بالجرانيولوماتيز؟ يعني انت جاوبت على سؤالي انه انت اذا كانت في جرانيولوما معناتها you have to give an anti-tuberculous irrespective of other descriptions. Once there is no granuloma and just you have a description, this will lead you to start with the steroids. So how do you start your choice of treatment اساسا يعني؟
It's your facilities
ايوه
كمان. It is
ايوه
determined by your
facilities.
facilities. Sending the patient to PCR is not so easy.
yeah.
Huh? It's
Yeah.
everything is
صح
paid by the patient.
صح. بعدين عندنا ما بده التريتمنت الا يكون عنده يعني مرات انا اي هاف تو كونفينس ذم. طبعا من يجي يقولوا ما في جرانيلوما وندي الاستيرويد وما ريسبوندينج، الامريكان ديل الا تجيبي لتر. فلكن في الاخير وصلنا معاهم لاجريمنت انه يا جماعه لسن الحكايه دي نحن هسه عندنا فيها جود ريسبونس وكده، ونحن موصف الكيسز دي عندنا التوبركلس اندمك وممكن نجي بدون الحاجات دي، ومرات بيكون هنا فاقتنعوا في الاخر. فبقينا انه زمان الا تجيبي يعني تجيبي هيستوباثولوجي ريبورت انه والله دي
في
جرانيولوما نوت اتس
tuberculosis.
كازيتنج دي توبركلوز، حتى يدل التريتمنت انه فيري اكسبنسيف لكن فور فري في السودان. فبنقوم
والله
في
يا
الاخر
مستر عمر احتمال تلقى عندهم الداتا. طيب ما دام بيدوك التريتمنت احتمال تكون الداتا
ايوه
عندهم
لا
متوفره
عندهم دي واحده من
وتفيدنا
الحاجات اللي انا
في
كنت
البيبر.
ماشي لهم.
ايوه
ما
فيري
يا
والله
نايس.
سارة
درمان
ما في حاجة
في
اتحرقت إلى الآن؟ سارة في حاجة ما
ان شاء
اتحرقت
الله
في
يكون عندنا.
السودان؟
احتمال برا قصدي
ايوه
المرسلين ده حقتهم ما هم امريكان ثم مرسلين لنا
اتليست كان طلعنا
اوتسايد.
اتليست 4 5 نرسلها ككيس سيريز ولا كده ونقول والله
Yes, you can write it. Yes.
ايوه
as
إن
usual
شاء
نحن
الله.
طبعا حاجاتنا كلها يا مستر ما documented.
مش
كلنا
كده.
كسودانيين
ونحن في الباثولوجي بالذات حاجاتنا ضايعة كلها.
ايوه
انا
والله
افتكر
ايوه
انه
والله
الناس
أيوة.
من
although we
من
do all the job.
الدسكشن دي، انا افتكر من الدسكشن دي طالما هي مالتي ديسيبلينري يعني ممكن تطلع بيبرز كتير. يعني لو في شخص عنده كيس مع ده فبتبقى الدسكشن، افتكر الزول اللي عمل البرزنتيشن ممكن انتجريتد يعني. وبعدين احنا ما شاء الله معانا فطاحله كل المجالات يعني. فاي ثينك الناس اللي اللي بيكون عندها التوبيك دي very easy to get the paper يعني. وبعدين قبال ما ينتشر الاي اي ويصعبوها على الناس زياده، فانا افتكر now it's not so that difficult to يعني حسب من التوبيك بتاع الليله ده في being organized very well and it's very interesting and very rare and very interesting and very in a scientific base. it have got يعني هذا الكلام اللي اتقال ده فيه a lot of scientific base ممكن يكون منه يعني it's going to be a paper strong يعني original article بتكون very good يعني.
احنا
تثبت
غايته
حق الناس ذاته.
الكيس يا عامنا الكيس اللي في السودان اللي لسه قلت لك عليها راديولوجيكالي شخصناها راديولوجيكالي دي وفعلا طلعت بيست على التراساوند فيتشرز انه الباك جراوند structures was not destroyed just يعني very fine subtle features discriminate الانفلاماتوري من النيوبلاستيك بروسيس وطلعت في النهايه granulomatous mastitis. فدي حاجه برضها
خلاص انا
ممكن
انا I promise الناس اللي قاعدين هنا دين انا I'm writing something about this، بس انا داير to document صور، عندي كم صورة هسه على خطيتهم هنا دين. ف
إذا
everybody
عايز
اي واحد
أنا
منكم
الكيس عندي
interested،
أنا
اي واحد
بكتبها
اي
وبرسلها
واحد
لك.
انترستد، لكن
بس
الحاجات من
الهست
النت ما عندنا
لا انا
صور
الهيستوباثولوجي ما
من
دي
النت.
ده ما قصدي انا I want to get
ايوه
الكيسز الهيستوباثولوجي صور عندي، والداتا كتبنا نحن الحالات اللي شفناها وكده. ما كلها قدرنا نلمها، لمينا هسه انا خاطين في مركز الثدي يعني خدت الحاجات لمية. فعندنا زي 10 هناك، وعندي 10 في امبيريال، والباقيين في كنت هو ده ما سجستد منى او امنه انه في بدأنا نمشي للامريكان دي نشوف الداتا اللي عندهم، رسلنا الكيسز هم عندهم، انه تكلمنا معاهم نحن وكنا بنرسل لهم الكيسز للتريتمنت وكده. فان شاء الله كده ربنا يهوينا بلدنا وترجع. لكن مين وايلي في الحكايه دي ما قدرنا، انا I think we can send an editorial letter لواحده من الجيرنال ان شاء الله.
ان شاء الله
ايوه
ان شاء الله.
ايوه
anybody
بعدين بقت فيري
interested
اوبن، بقت دايره لها
will
حبه
ask.
قاعده، لكن يعني اتس فيري، بعدين اتس فيري امبورتنت حقنا حتى، لانه هسه انت بتلقى مثلا احنا هسه بلقى كثير الهنود الباكستان، واحنا عندنا ريتش داتا وعندنا ريتش ساينتفك بيز، فحرام يعني
lot of it.
للأسف
اللوت
يا
اوف ات.
أمنة
وبعدين
ما
انت قريتي
بنكتب نحن لأنه يعني very busy في الشغل بتاع الدايجنوستيك بارت، وبننسى الحكاية دي.
غلط لكن
أيوة ده
بعدين
غلط طبعا.
هسه انا قدر ما افتش
بس
الريفرنسز، نادر لما تلقى ريفرنسز فيها داتا من السودان، حتى بتلقى
ايوه
اسماء دكاتره سودانيين، لكن ما بتلقى الداتا بتاعتك. واحنا عندنا فيري ريتش داتا، يعني مثلا فكره التوبركلوسس الجرانيولوماتيس ماستايتس دي فيري رير، وهم ما عندهم لانهم هم ناس يعني ما عندهم الانديميك ديسيزز، حتى لما انت تنشرها كرير كيس بتكون ريلي رير كيس، يعني لانه مره تلقى انت، انا هسه براجع بلقى كيس رير كيسز ما رير كيسز يعني اساسا. ف يعني الحلقه الساينتفيكالي للناس اللي قبل ما شاء الله يعني انتوا كلكم اساتذتنا،
ايوه ايوه
it should be
ان شاء
يعني
الله
ان شاء الله.
ان شاء الله.
خلاص يا امنه
وريدي على
انت
التايم شخصيا، ريدي
ربنا
هتخشي
يرجع
معانا نحضرها.
السودان يا أمنة.
حاجه ولا انا ريدي في اي حاجه، يعني انا مشيت في المجال ده هسه شويه، بقى عندي بابليكيشن شويه ومشيت وعايزه اقدم لاسوشيت وكده، فام ريدي، ومخي الايام دي مفتوح للحاجه دي، فام ريدي
خلاص
ان اني ثينج يعني.
طوال يا امنه شجعينا.
راح يكون نواه بتاعت عمل مشترك باذن الله بابحاث، فان شاء
ان
الله
شاء الله يا
ايوه
ساره.
ان شاء الله
باذن الله
ان شاء الله
شجعنا
ان شاء الله
ان شاء الله.
ان شاء الله.
خلاص I think it's time to conclude.
ثانك يو.
فأنا أشكركم جميعا، أشكرك يا مستر عمر، دكتورة نادية ضو، فعلى البرزنتيشن الجميل صراحة very nice talk and very good informations, and we hope we can contribute إن شاء الله with you in another meetings إن شاء الله. فشكرا لكم جميعا، وشكرا لكل من ساهم معنا في الدسكشن. يديكم العافية.
شكرا جزيلا.
شكرا
شكرا
لك.
شكرا
Nice
لك
to
يا
meet you all.
مستر، وشكرا يا
شكرا.
سارة
Nice to meet you
ودكتورة
all.
نادية،
شكرا يا
وشكرا
رباب.
لجميع
تصبحوا على خير.
المشاركين. شكرا لكم جميعا.
ربنا يسهل. يلا شكرا لكم.
شكرا.